Hello from Kisumu side. Who is there? Here we have Chite. We have Silvano. Who else? Say your name. Anyango. Dorothy.
Is Dr.
Carol Clutch. Ellie.
Chris, morning.
Moniki.
Hello, morning.
On call. Who is on the other side? Hello.
Dr. Koile, morning.
Yes. Good morning.
Hello. Dr. Koile.
Okay.
Kisumu.
Who else?
There is Dr. Ganda.
Dr. Ganda. Morning. Who else?
There is a medical student, Ajuang.
That medical student has a name.
Ajuang.
Okay. Next.
Ajuang.
Achuang. Morning. Okay. If that is all, we are going to start, and Dr. Mwaniki is starting with his case. So if you can hear him, let us know so that we continue.
Hello, can you hear me clearly? Hello, can you hear me? Are they able to hear me? Bora? Anyway, so I'll get started. He's confirmed.
Can they hear me? Hey, Kisumu people, can you hear it?
No, they can't.
You have lost
Yes, you can.
Can you hear us?
Yes.
Okay.
Okay, we start.
Okay, so thank you so much for attending Tumor Board today. I'll start with the first case, which is a case of, how do I move it? Okay, so it's a case of a person known as E.T., who's a 75-year-old male. So E.T. presented 4 months ago with a 3-month history of progressive neck swelling. This was painless and associated with difficulty in breathing, which was worse when he lay down supine, and at the same time, he reported difficulty swallowing. So there was no report of fevers, sweating, loss of weight, or any other swellings on the body. So basically, no big symptoms for lymphoma. At the same time, he did not report any thyroid symptoms, nothing to suggest hyper or hypothyroidism. It's of note that E.T. did not have any history of gastroesophageal reflux disease or any other major illness, and that he only has been drinking beer only on weekends, on average 6 bottles. He does not smoke. So E.T. retired 10 years ago as an accountant in the civil service, and that is all that he ever did for work. So on the initial encounter, we did a physical exam on him, and what we noted is that he was in fair general condition. He did not have any pallor, jaundice, cyanosis, or dehydration. Cardiovascular exam was normal, same for abdominal exam and the CNS exam. Are you okay in Kisumu?
Yes, we are.
Okay. So cardiovascular, abdominal exam, and neurological exam was normal. Respiratory exam, there was wheezing, loudness in the expiratory phase, and we examined the neck, and what we found was a soft and tender anterior neck swelling covering the lower anterior surface of the neck. The width was around 15 centimeters, and the mass was extending into the chest behind the clavicle. Some investigations were done, and of course the CBC's renal functions and liver functions were within normal limit. A histology on the mass was done on a biopsy, and the conclusion was features suggestive of a thymoma. A CT scan of the chest showed a mediastinal mass, and this mass had surrounded the major vessels around the neck, and that would put the thymoma at stage 3. There was no mediastinal adenopathy from the scan, and the person who interpreted the scan thought that there was a high likelihood that that was a thymoma. But of course, we can't make a histological diagnosis from radiology. So we decided to start ET on treatment since at that moment it was not possible for the mass to be excised because of the vessels of the neck which were involved. So we started him on cisplatin, doxorubicin, and cyclophosphamide. And at the moment, he's completed 6 cycles. The anterior neck swelling that was there before has significantly reduced in size, and currently there is no palpable mass. The symptoms that he presented with are no longer present. That is the difficulty breathing when laying down supine, the difficulty swallowing. So that is more or less resolved. Now, the reason why I wanted us to discuss this case, first of all, is because this is likely the first case of thymoma that we've seen in our facility. So it's a significantly rare tumor. The second, oh, okay. Yeah, it's quite rare compared to see a breast, see a cervix. And I thought it's important that when you've seen a patient out there and they have a neck mass, you include that as one of your differentials and not just lymphoma or a thyroid tumor. And then whether at this point we could do radiotherapy or surgery, should we repeat scans and see that now the tumor has shrunk significantly in order to, allow us to come up with a maybe more definite form of intervention. And we're lucky to have Dr. Chite here today because he's had a lot of experience on such patients.
Actually, I have. So.
Oh, thank you. I thought it was funny.
So it's true. My preceptor, Pat Lair, is actually a thymoma specialist in the US. He's written all the protocols on thymoma and thymic carcinoma. So all of us as fellows, we rotate under him for at least 6 months. So we've seen the most number of thymomas of any doctor around the world, probably, through his clinic. So this is not uncommon. So the only question I have, let's go back. There are several things that are missing in this patient. Remember, whenever we have a patient with any mass or any, we did not measure the sizes of these parts. So when you start a treatment, let's go to the next. So we are just saying there is a neck, soft and tender anterior swelling covering the lower. Okay, that is done. About 15 centimeters. But where is the CT scan with all the measurements?
So
that showed various, because as you are treating this patient, you shouldn't just do the 6 cycles without really measuring whether this patient is responding or not, because some patients actually do not respond as well on that chemotherapeutic regimen. So we needed to have the mass was initially 15 by 4 by 12, and it had some other metastatic disease that are seen. The number of lymph nodes and the level of the lymph nodes should actually be monitored, because that is actually important when you are thinking about what other modalities to do. So that is what is missing in this number 1. Yeah.
So thank you so much for that. This is an outpatient, and I talked to them. They say they are coming today, and I thought I would get an opportunity to get the scans and report clearly on them next week.
Yeah. So what we need is, at the time of diagnosis, what are the specific sizes? Were there any lymph nodes associated with it? When you did the chest CT scan, with IV contrast, what are the other lesions that were seen? The sizes of each of those lesions is important. Then number 2, let's go to the next. So usually when we are doing these 6 cycles, you need to actually give 2 cycles first, and then you ask them to actually do another CT scan so that you know whether they are responding or they are progressing in their disease before they finish. Then do we have any, how long ago did they finish the treatment? This 75-year-old. 3 weeks ago. So then today, one of the things to do is actually to repeat CT scan and compare it with the previous CT scan to be sure that the lesion has actually completely resolved. If not, we see where where we have any other lesions that can be seen. Now, from that CT scan, it's what you'll decide what to do next. Usually, the treatment of thymic carcinomas and thymomas is, we involve all the disciplines. So you have chemotherapy, which you've already given, with what seems to be appreciable response, at least from clinical. And then they would probably benefit from radiation if you see any mass that is remaining, because 6 cycles is usually the maximum we give. You radiate the sites that are remaining. And then after that, once the patient finishes radiation, you go for 4 to 6 weeks, and then they'll require another scanning to see whether there is any other lesions that can be seen at that time. If there is, now that is the time the patient is amenable to surgery. Otherwise, doing surgery without knowing where else the disease would be, it actually would not be good for this patient.
Thank you for that input. Initially, we did not have any signs of distant metastases. The tumor was locally invasive, went through the capsule to the fat, which is surrounding the thymus, and the vessels around that. Now, I have a question for you, Dr. Chite. According to literature, we know up to 20% of such patients get to experience autoimmune diseases, say like myasthenia gravis. So, how often have you seen that in reality?
We've seen a few patients, but what happens is that some of these patients who already have some autoimmune diseases may actually be predisposed to getting thymic carcinoma or thymoma, as you know the functions of thymoma, thymus in patients. So we see a few of them, but the patient would actually present with other symptomatology. So if he's already responding, you're not seeing pure red cell aplasia or any other abnormalities, then most likely this patient are just isolated thymoma without any other symptomatology.
Thank you. Any other questions?
And then the other thing is that we need to follow up with the pathology because just reporting with thymoma is actually not sufficient. You have to grade them. We have various thymoma grades. There's 1, 2, 3, and each one of them has an implication in terms of survival and prognosis. So it's important for us to actually get more pathology details. This is actually a case you can write a case report on because, as you said, which is true, you don't often see this.
My comment, Professor Chite, is we started the treatment. We started the treatment based on a hunch that it could be cancer, right? We didn't have any histological proof that it was cancer. I don't know if this is the standard of practice when you have a hunch, then you just start chemotherapy.
Now, you know there is a reason why I'm not a hunch doctor. So we should not be starting any treatment on hunches. Do we have do you have the diagnosis?
Yeah, we have a pathology report.
Okay, good.
Okay. I didn't see it.
So I did not print or copy the whole of the pathology report,
So,
but I just showed the histology, which is suggestive of thymoma.
So the thing I would actually request for this presentation is that 1, we have the equal performance status of each of these patients. 2, we have the diagnosis, and if you can just take the picture or you get the entire pathology report, how it looks, because there are some specific things you just ignore. Because if you told me I have a 35-year-old with breast cancer, you've told me nothing. There's a lot of features that I would really like to know from that breast cancer. So the entire report is actually very essential. And then obviously staging from the beginning, which we already have. And for the purpose of these meetings, because people do not really know how to stage thymoma very well, you need to actually say what specific features on the CT scan put this patient to stage 3. So you can actually pull out the staging of thymoma, stage 1, 2, 3, or the 3, just the 3, and then black out or highlight the areas that this patient had that made them stage 3. That would be very educative.
Okay.
Any other questions on this patient?
Yes, Dr. Chite.
Yes.
Hello.
Hello.
This Dr. Isura.
Yes.
Just a question for the general group. How was this histology obtained?
So, from what I can recall, we had an FNA.
Oh, it was an FNA.
And they did an FNA first and then a biopsy of the mass. Yeah.
Oh, okay.
Yeah, because on FNA, you may not really be able to differentiate.
Anything,
I mean, it's very abnormal for somebody to put it on FNA.
Yeah.
It will just show some abnormal tissues with no characterization. So they must have done a core. But we really need to know. That's part of the reason why the pathology report is very important, because it tells you what sample was taken, how many samples were taken from the specimen, and whether they use because you can actually make the diagnosis from just the cervical lymph node. You don't necessarily have to get ultrasound guided biopsy or CT guided biopsy from the anterior mediastinum. If they already have some lymphadenopathy, the easiest lymph node to get to can give you the diagnosis.
Okay, thanks.
Any other questions? We'll be moving to number 2. If we don't have, but for this one, there are several things that are unresolved. So Dr. Mwaniki will present to us this data, or at least send to the hematology group. with the heme group, the pathology report, just a copy of it, the staging itself. The patient comes today, so we'll do other staging to see post-treatment, and then we can actually definitively say what is the best plan.
So Kisumu people will load your presentation. Are you okay to start?
Hello.
Yes.
Okay, so we're just going to load our presentation.
No, we are getting it from here. So we can start with just, which one do we start with?
Just a minute, we're going to load for you.
So you are loading from your side?
Yes, yeah, we're going to load it from this side.
Okay, fine.
Are you able to see the slide?
Yes.
Yes. Okay.
Just put it on a presentation mode. Slideshow.
We are ready. Let's start.
Okay, can you see that?
Not yet.
We can see the slides. Can you please put it on slideshow? Then you can start. We can see the slides.
Okay.
Okay, go ahead.
So I'll start. So this is a case of breast carcinoma. Now the patient is JAO, 56-year-old, who was diagnosed with breast carcinoma, right breast carcinoma in late 2017. She had had complaints of breast swelling, change in skin color and texture over the right breast, and nipple retraction that had been there for over 1 year prior to presentation in August of 2017. So cough was also present at the time of presentation. That was 2 months prior to the time she came in. Past medical history, there were no prior admissions, no blood transfusion done given to the patient. Social, there are no histories of cancer in the family, not any other chronic illnesses. The patient was, however, hypertensive and was on enalapril and aldactone. Food and drug history, there was no known food allergy history, and reports was that she was allergic to diclofenac. So the patient thereafter was worked up for chemotherapy, was given ACT therapy, worked up for ACT therapy. She received 1 cycle of AC, then developed CCF 2 weeks after cycle 1, had to be admitted for that. So after that, a decision was made to have the patient continue on single agent paclitaxel. So as we're speaking right now, the patient has received 6 cycles of paclitaxel, the 3 weekly at 175 milligrams per meter squared, and the last cycle was 2 months ago. She's on letrozole 2.5 milligrams daily, and she could not afford Herceptin, so has never been given. So this was, as per presentation, the breast ultrasound report that showed a subareolar breast mass that was 1.7 by 1.7 centimeters with associated breast edema, nipple retraction suggestive of neoplasm, and was put at BIRADS 4. So a mammography was indicated and a CT scan also. After that, a mammogram was done that showed a retroareolar mass at the right breast, still put at BIRADS 5, highly suspicious of malignancy. So then an ultrasound guided biopsy was indicated. So with that, another breast ultrasound was still done that basically gave the mass to be a little bit bigger, 2.1 by 1.9 centimeter, that was associated with skin stroke subcutaneous edema and nipple retraction suggestive of malignancy, still at virus 5. And then there was minimal increase in size compared to the previous scan. That was the first ultrasound done. So this was the histology report that was done. So the first one, it got it to be in an invasive ductal carcinoma, no special type. The overall histological grade was at grade 2, a total score of 6 or 7 given. So we having a grade 2 invasive ductal carcinoma, no special type. So immunohistochemistry was indicated, which was then done, and it was found that it was estrogen receptor positive, PR positive, and HER2 positive. So with this, that's why the patient was given letrozole, was advised to be given Herceptin, but she could not be able to afford, so that was not given. So as per that time, a chest X-ray was done that showed no evidence of pulmonary metastasis, but just pneumonitis. And a CT scan chest was done. So with that, these were the findings. There was a right breast tumor with lymphadenitis carcinomatosa, bilateral small pleural effusion. The right side was more than the left, with widespread osseous metastasis, and enlarged right intramammary and axillary lymph nodes. An abdominal ultrasound was done that showed a normal abdominal pelvic ultrasound. So this is how the patient looks like today. That was 1 week ago. So we still have skin, some form of pudorang with nipple retraction. The mass is still retroareolar. If you feel it is like approximately 3 by 2 centimeters, the patient is at ECOG 1. So that's how the breast looks like. So now we did a repeat mammogram, and this showed increased right breast retroareolar density with areas of coarse calcification, with right nipple retraction and skin thickening. The left breast upper outer cornea quadrant 0.6, well circumscribed opacity, scattered intraparenchymal calcification noted. No left breast skin thickening or nipple retraction. So impression notes features consistent with the right breast carcinoma, and a comparison with the previous mammogram imaging was necessary. So why we decided to present this patient? So we were like, what next? Is the patient still liable for surgery? Can we still give the patient Herceptin? Or is there any role for second-line chemotherapy now that she did all her 6 cycles of paclitaxel? Or can we still continue with the paclitaxel? And are there any tests that can be done to this patient? Thank you.
Thank you so much, Dr. for that great presentation. So I'll allow people to ask questions first, because I have a million of them. But let's go around the room. Any questions? Questions, comments?
Hello, I just wanted to find out, why do you keep repeating the imaging, the mammogram and the ultrasound?
Okay, these other ultrasounds, those ones were done initially before the patient was put on any medication. But then the last mammogram, because there was still this mass that was present in the breast, albeit these getting all this medication, I just wanted to know if there was any change that was present. So that's why we did the last mammogram.
Okay.
But for the first, I can't really explain.
Okay, next question or comment. Can you hear us? Hello? From Kisumu, can you hear us?
Yes, we can.
Okay.
Okay, I have to find out if you have a baseline echo or
Would you kindly speak up? I can't get you.
Dr. Monique? Maybe.
Well, there's a question here. Somebody is Dr. Mani. And when you ask a question or give a comment, please say your name so that we know. I mean, your name.
Hello. So,
Yes, hello.
did you have a baseline? So, my name is Dr. Maniki. Sorry, I assumed that my sound is unique. My voice, I mean. So, did you have a baseline echo or EKG for that patient who developed CCF? Because maybe there was an underlying cardiac problem that may have been worsened by the adriamycin.
Yeah, that's unfortunately we didn't. The reason for just we didn't actually. The CF just that tipped people to stop the giving the patient adriamycin and changing over to paclitaxel. So there was no echo or EKG done.
Hello, this is Eli from Gyne Oncology. From this presentation, I think this could be a very sick patient. And I think we should ask ourselves, what is the goal of care in all this, even the decision that we'll make today?
Any other question? Okay, so this is Chite. I've got several questions for this question. One of the things is that for sure it's very important for every patient who is put on adriamycin or doxorubicin to actually have an echo prior to. I know the practice has always been we don't do it as often because quite a number of our patients usually cannot afford. However, as you've seen, this 56-year-old woman who is relatively healthy, otherwise went into heart failure, which is it's not uncommon. So I think from this, especially because she was able to do all these mammograms and all that, I think she could have easily done an echo. So we could actually try to, any patient who is receiving or is about to receive adriamycin or doxorubicin, that is the same, needs to have an echo prior to. Then the other thing that this patient had, when we look at, first, I don't really think we have any reason. Once we had done that ultrasound of the breast and we've already seen the breast mass, really the next step, we usually just go straight to the CT scan, trying to stage them. So CT scan of the chest, CT scan of the abdomen and pelvis. Quite a number of people are not comfortable when we say we can actually change that and even do a chest x-ray or abdominal ultrasound. That is a poor man's investigation. So we usually do imaging with ultrasounds and chest x-ray where the patient cannot really afford a CT scan. However, the standard practice should actually be CT scans in order to stage. So that when you're presenting this patient, you know this is a 56-year-old with stage 3 breast cancer. I did not hear any mention of the axillary lymphadenopathy, so I'm not so very sure whether from clinically or from CT scan, whether we saw any of that. Then the other issue is actually to do with the pathology report was actually pretty good, and it gave quite a lot of information on management of this patient. However, I would not actually repeat this mammography routinely. Then the other question is, once the patient was not really doing very well on AC, unless their performance status has worsened, like she is equal 3 or 4, then this patient should have been given 2-drug regimen at least, at the very least. So you could have actually given even CMF, like as long as you remove the adriamycin instead of a single agent. And single agent paclitaxel, has not been shown to be as effective as single agent docetaxel on its own. So when I'm choosing which agent to use in this setting, I prefer, I would have actually continued with DC, with cyclophosphamide still being on, because she did not really have any reaction to the cyclophosphamide at all, and give docetaxel. So I would have given dosi and C. When you look at this lady, as you've taken the picture for a week ago, which is actually a pretty good picture that you can see very well. Unfortunately, she doesn't seem like she responded at all to the paclitaxel. So I would not really give this patient all those cycles, 6 cycles, because it seems like even when you are giving the cycles, you're actually progressing. When you look at that breast, other than the skin, induration and all that, and nipple retraction, I think there is a mass behind there that is a little bigger than just the 2.1 by 1.9. So I think this is where, whenever you're giving any treatment for a cancer patient, it's important where you give initially 2 cycles. If you are giving 6 cycles of any treatment, give 2 cycles first and evaluate the response. Because if they are not responding to that drug after 2 cycles, they are highly unlikely going to respond to it when you give them 6 cycles. So this is a patient, I would say that perhaps that paclitaxel was not really being effective as a single agent in her. So would have given two drug treatment. Now, this patient, where she is right now, and at least she could afford letrozole. The issue about Herceptin, yes, you are very right, that this is a patient who should have been given Herceptin as well. And Herceptin can be given in 3 major ways. You can give Herceptin in the neoadjuvant setting. So like right now, if this patient is stage 3 at that time, not now, because the CT you've told us about seems this patient is stage 4 because has metastatic disease to the bone as well. So if this patient was stage 3 at that time, then Herceptin would have been indicated in addition to the AC. So you would have given like AC plus Herceptin at that time at the initiation. And at the time when the patient starts having a reaction to the adriamycin, would have done DC plus Herceptin. Or TC, which is Taxotere. So the only other question, and Herceptin in our setting is very hard to come by. It's very, very expensive. We've been discussing about patient assistance program with Roche, the company that actually manufactures it. So we are likely to get this drug in the market. However, the patient can still be treated with Herceptin in future if it's found and the patient is able to afford. At that time, we are giving that Herceptin as every 3 weekly for at least 18 cycles. So for now, where the patient is right now, I think the bottom line is this patient is at a point where she's stage 4 disease with the metastatic disease to the bone. She still has this mass that has not really responded to the chemotherapy we've given her. And right now, I would not really give options of surgery. Any patient with stage 4 disease, breast cancer, surgery is actually not really indicated. There are very, very few situations where you will want to send this patient to a surgeon. Like, for instance, if they are just doing toilet mastectomies or they just want to clean up some wounds before you treat. Otherwise, it has not really been shown in clinical trials to have either progression-free survival or improvement in overall survival of these patients if they have surgery. So that mass, as long as it's stage 4, does not really necessarily give a negative prognosis if you leave it in, as long as you treat her. How I would approach this patient right now, you're saying she already has some pleural effusions, she has bone metastatic disease, and she has that mass that is still there, but she's ER/PR positive. So I would continue on an aromatase inhibitor, so if she can be able to afford that letrozole, that's fine. I would actually change the treatment to capecitabine, Zeloda. You could give oral Zeloda. And then you give at least 2 cycles and monitor whether this mass is actually responding. And then I would add zoledronic acid to this patient's treatment because of the metastatic disease to the bone. And then evaluate these patients whenever she comes. We measure, right now you should measure the disease as it is now. If the CT scans and all that were done last week, that's fine. Or in the last 2 weeks, that's okay. That becomes the baseline. And then after 2 cycles, you need to measure that again and see whether she's responding. So oral Zeloda, oral letrozole, zoledronic acid, following up with the imaging to see whether she responds. The good news, there's some good news and bad news. The good news is that a patient with ER/PR positive disease, they actually have a better prognosis even when they're stage 4. And we've seen quite a number of them go on to live for several years. However, the bad news for this patient, unfortunately, is the HER2 positivity, considering that Herceptin cannot really necessarily be gotten. We need to fill out her NHIF forms. At least she can get a few cycles of Herceptin and get that going. So I would like some comments from your side in all this.
Thank you. I think you've added a lot.
So if there are any questions, we can talk offline. But the presentation was very, very good. But we just want fewer imaging do more of just the routine imaging that we normally do, which is just of the chest, and monitoring the disease whether or not during treatments. Thank you. Next slide.
Thank you.
Sorry. Can,
Sorry, there is a case from our side.
okay, then we also have another case.
For your case.
Probably once you're done, we can upload it.
Sorry?
We also have another case.
You have already.
Yes, we have it. Can it go on?
Yes.
Hello.
Have you loaded the presentation already?
Yes.
Okay, we can't see it.
Just a minute.
Okay, so this is another case on breast cancer. So a 21-year-old female patient who presented with breast mass was diagnosed with right invasive ductal carcinoma, no special type, grade 3 breast cancer in November 2017. So she was seen by a surgeon then, and the tumor was deemed to be inoperable and was sent for neoadjuvant chemotherapy. He stated that if the tumor was to be removed, that there would be no skin for closing up the wound. So she received the first cycle of adriamycin and cyclophosphamide back in December, but then got lost to follow-up for 3 months because of finances. So as per now, she's received 5 cycles of AC and then 2 cycles of paclitaxel. The last cycle was given last week. Not yet done immunohistochemistry and no imaging done yet. So the patient is not an NHIF contributor. There's no history of any chronic illnesses in self or family, but of note is that this patient is a dwarf. So on examination, she's at ECOG1, fair general condition, not pain, not jaundice, not cyanose, no lymphadenopathy, noted. The breast examination, the left breast, there were no masses palpated, although it looks a little bit funny. You'll see the imaging. The right breast, the breast tissue has shrunk all the way to the chest wall, no masses palpated, and other systems are stable. So this was what the surgeon gave when he was referring. He said that he'd reviewed the above named was who had already been established to have a ductal carcinoma of the right breast. That on local examination, the tumor is locally advanced, fixed to the underlying tissues, and surgery will not be useful at the moment. So this was the histology report. It showed the conclusion was given as an invasive ductal carcinoma, no special type, grade 3 Nottingham score. So was recommended to do ER and PR analysis. The lymph node sampling, there was no lymph node sampling that was done. Yeah, basically that. And all the margins were involved with tumor, and there was lymph vascular invasion present. So this is how the breast looks like right now. We can only see a portion of the nipple remaining, but the breast tissue is all shrunken to the chest wall. That's now in comparison to the left breast. Although there are no masses palpated, but this nipple and the areola tissue looks a little bit funny or different. Yes. So my question was, what next on this patient? I sent them for immunohistochemistries. We decided as a team to go for 6 cycles of paclitaxel. And now that the tumor has shrunk all the way to the chest wall, that was our major concern. Is there still, okay, we don't know what next for this patient. If you kindly add on to any points for us. Yeah. And of note is that the challenge has been finances all through. Yes.
Okay, thanks, Dr. for that presentation. So I'll open this to the floor for questions, comments, and additions.
How big was the mass originally? It's hard for me to appreciate the progression of this. Is this better with chemotherapy or not?
Unfortunately, I really can't tell how the initial mass was, apart from what the surgeon gave us, that the tumor was locally advanced to the chest wall.
What did the patient say?
So the patient herself is saying that she's gotten way better with the chemotherapy medication.
This is Dr. Mwaniki, and I have a question, which is a bit technical for Dr. Chite. I'm concerned. It's still about the case anyway, but thank you for having the patient for us. So I'm just concerned about the age of this patient. She's only 21 and she has a CA breast. What she has is achondroplasia, which is also the same thing as dwarfism. And we know that the gene which is responsible for that is the fibroblast growth factor receptor 3 or 4. And I'm wondering if that mutation has got something to do with development of CA breast in this patient.
So I would say it's very hard to say, but I totally agree that being that very young, these are the kind of patients you want to also send for the BRCA and see whether they have some other abnormalities that will dispose them to this. There's a high likelihood that such patients they have a higher rate of these factors than the general population, but you cannot tell until you send for mutational analysis. So I would highly recommend, and I totally highly recommend for BRCA 1, 2, another foundational mutational testing.
Okay, thank you.
Other questions not addressed to me. Anyway, so in the interest of time.
Is there lymph nodes? I did not appreciate in your presentation whether or not there was lymph nodes palpated on the right X-ray.
I didn't get any on palpation.
So, Doc, if you look at some of the results, let's go back. Let's go back on this slide. I think we know the size of this mass, how big it was before. Just go back, start this presentation again, and start going through. No, that one. Okay. Stop there. Just a minute. Okay, next. Yes, this one. You see there, they've written clinically. Can you see at the clinical place? There's a female with a hard right breast mass measuring 15 by 15 centimeters. Can you see that?
Yes.
Yeah, I saw that too. So I think we know the size of this mass, and I agree with your surgeon that this was very huge for you to go straight to surgery. Obviously, the role for surgery in this patient is local. We really want to remove as much tumor as possible. And if there is no spread, with negative margins, if there's no spread, to ensure that we can potentially cure the patient. So when you have such a huge mass, this is a patient who is likely to already be at least stage 3, at least, before we do other investigations to figure out whether the patient was stage 4. Now, one of the things I would really like in all the breast cancer presentations is the age of the patient, the tumor size itself at presentation, ensuring that we have the stage of the patient, the performance status at that time. So I want to hear, like, this is a 21-year-old female, black of course, who has a right-sided 15 centimeter by 15 centimeter mass that has been growing for this period of time. I also want the HIV status if we can get, because all these things I'm mentioning, they have implication in the choice of therapy and the prognosis of the patient. But I also want to be hearing the stage. Is this stage 1, 2, 3? Stage and grade are different. So when you hear this patient has grade 3 disease, it actually just means that this disease is actually fast growing. So if you are to do the Chi-67, it's going to be very high because this is a tumor that is very aggressive. And that is actually expected because tumors in younger patients usually is a little more aggressive than the older folks. So knowing the grade is okay because it gives you an impression of which treatment you want to give, a strong treatment to really reduce the growth. But then you also need to tell me that this was stage 3 clinically at presentation. And that is important because it also gives prognosis information. Now, when you gave 5 cycles of AC, 1 cycle of AC and the patient was lost to follow-up, and it came back and you gave 5 cycles, 3 months of break in between treatment is such a long time that you cannot add it to the previous treatment. So like after 3 months, this patient is as good as a new patient when you are seeing them. So if you gave 1 cycle and a patient got lost to more than a month really for a 3 weekly treatment, then that patient, when they come, you have to look at treating them until you complete the cycle. We know that with adriamycin, the lifetime total dose that you are thinking about to avoid is 450 milligrams per meter squared. So as long as you are within the 450 milligrams per meter squared, to 500 really, but I usually like to keep it at 450. And having given these cycles, you get 5 cycles and you are using, I assume, 60 milligrams per meter squared. So 5 cycles, you already were at 5 times 60, which is 300. So you still have extra, you would have given 6 cycles completely. Now, the surgeon's note says that we need to give neoadjuvant therapy to downstage the tumor. We do not downstage tumors with neoadjuvant therapy. We downstage them, not downgrade them. The grade will still be the grade that it was because the grade is actually what is seen on histology. But the stage we can downstage by moving it from 15 by 15 to less than 5, which can actually put them at a smaller stage where the surgeons can have negative margins and remove the tumor. We need to be interrogating the axillary nodes because that one actually has an implication in terms of survival as well as in terms of what you prognosticate the patient. So I think where the patient stands now, immunohistochemistry is important, ER, PR, HER2, which I don't really have heard of at the moment. This is a patient that we can take care of in our upper breast and cervical cancer control program. So get hold of Muyodi so that we can help them with finances to get the treatment. Then the other thing for this patient, we do not really have funds to do BRCA mutation testing, but this is a patient we can get blood and stool so that we can be able to, if we get money, we do BRCA testing. Because then if she is BRCA mutation positive and her tumor was stage 3, then after treatment, we still have a potential of ovarian cancer and potential of another breast tumor on the other breast, especially if she has these mutations. So there are several things to do for her, do ERPR and HER2 testing. This tumor seems like it responded very well from 15 by 15. Whatever you showed us over there looks like it completely disappeared, if you ask me. But we need a CT scan of the chest and abdomen and pelvis, CT scan with IV contrast to be able to see whether there's any lesions that can be seen. And I would actually really prefer this patient, if this patient can be evaluated by our surgeons here, Connie, Dr. Lugaria, and team, just to see the potential for which kind of surgical excision can be done, and also to review the other left breast, because there's a likelihood that what we are seeing is either early beginnings of Paget's disease or there's something else on that breast. Looks a little bit looks interesting. So we may want to do some biopsy over there. And with patients with Paget's, some of them may have some carcinoma in situ that we may need to do. So I think this patient needs quite a bit of workup. If you do the CT scans or send her over here, then we can review her in a multidisciplinary setting and we can give feedback to the team. So we don't have any questions from you guys from this, our thoughts on the patient. Hello?
Hello.
Any questions or concerns or comments from all these thoughts?
Good morning, Dr. and everyone. I'm Dr. Dagi. I just wanted to give an input on the patient because I had also started managing her. What I'd just say is she's not able to afford at all even the imaging of the CT and
Okay,
abdomen. So
no, don't worry. For the social part of it, we'll take care of it. I'll do her CT scans and I'll do her transport to come here and go back. So that one, just liaise with my team. We'll give you a number. I think you probably have Muyodi's number or Pamela Were. We'll organize and have her get all that care. So don't worry about that. There is another.
My name is Anne. I confirmed, why are you guys using paclitaxel instead of docetaxel, like what we do here?
Did you hear the question from my wonderful nurse?
No, you can repeat the question.
Her question was, why is the preference for paclitaxel instead of docetaxel?
Well, initially, actually, it's availability. That's what we have. But now we have docetaxel, so I think we can move on to dosi.
Okay, we'll sidebar this issue at some point, but it's okay. So I think somebody will reach out to you. We need to organize. I'll give you the to get this patient here. Then this patient can be brought here. We do CT scans and all that. Then we send the patient back to you with some follow-ups and care. So thank you for bringing this one up. There's quite a lot to be done on her.
Thank you.
Next, please. So we have a case here from our surgical colleagues and presented by Silvanus. He's ready and go.
Good morning. I'm Silvanus. I'm presenting a patient from the surgical oncology. Patient is JSO, 59-year-old male from Memphis, with a diagnosis of a locally advanced gastric carcinoma. 59-year-old patient diagnosed with gastric cancer in April 2018 via biopsy, having presented with persistent vomiting, anorexia, and loss of weight. An OGD was done, which showed a finding of a thickening gastric wall, and a biopsy was taken with a diagnosis of a poorly differentiated adenocarcinoma, signet ring type. An ultrasound which was done showed a circumferential wall thickening of a gastric wall, which was evident at segment 4A of a liver is a focal area of a fat infiltration with no evidence of parenchymal metastatic lesion. CT scan was done. Chest, which visualized an upper abdominal organ, shows irregular circumferential gastric wall thickening 2 millimeters at the body and fundus. Patient was started on a neoadjuvant chemo on 20th April, docetaxel, cisplatin, and capecitabine, and has so far done 3 cycles with marked improvement. Patient so far is doing well, no presenting complaints which have subsided. CT scan was done post-chemotherapy with an impression of cardiac and body gastric wall thickening is in keeping with diagnosis of a CS stomach. No abdominal lymphadenopathy was identified. Past medical surgical history and family socioeconomic history was unremarkable. Review of system unremarkable. On a general exam, patient was stable at EGOG 1. Local exam, there were no, it was unremarkable. Vitals were within normal. Summary, a 59-year-old patient diagnosed with locally advanced, poorly differentiated adenocarcinoma of the gastric in April 2018 and was started on neoadjuvant chemotherapy this year, and has so far completed 3 cycles and has showed marked improvement post-chemotherapy. Lab works were within normals. Just to comment on the last UEC which was done, which creatinines were high on the last, on 27, that's on the last chemotherapy, when she got the last chemotherapy.
So what's the question?
The question is, what's the next plan for this patient? We have investigation which was done. Yes. Yes.
Make that smaller. I think your copy paste was too big. If you make the picture smaller. So this was a case I had seen in surgical oncology clinic on Thursday. For those of you guys here who don't know, we have surgical oncology clinic. So if there's a patient you think needs surgery, please refer them. It starts around 9:30 to 10 o'clock in room 4 downstairs. So this patient's cancer has a very bad prognosis. One, it's poorly differentiated and it shows signet rings. The question is whether or not we should offer surgery. At this point, there's nothing that contraindicates a surgical intervention, although we know that probably by the time we take the specimen out, when we look at it under pathology, it will be bigger than what we are impressed with right now. I actually sent him for endoscopy on Friday just to make sure that if we go in, we have a margin to anastomose to, because what this patient will get will be a total gastrectomy. The endoscopy did not show anything, but we know with lineoplastica that it's usually not a gross invading tumor that you see macroscopically, that this infiltrates in the layers of the mucosa, and so it's something that as a surgeon, we won't actually see probably the gross tumor. It's something that you only see microscopically. So I think at this point, I'm preparing him for a total gastrectomy, although I'm very hesitant that we are actually going to give him a cure. My next step will be to do a diagnostic laparoscopy to minimize the morbidity of an incision and make sure there are no gross lymphadenopathy when I go in to look with a camera. If there is, I will stop there. And if there is no gross lymphadenopathy, then we will proceed with total gastrectomy.
So do we have some questions from the Kisumu side before I ask my own? Any questions?
No question. No question.
Okay, so generally these patients, as Kani has said, it's very true. Generally these patients with gastric carcinoma, especially, generally gastric cancer is a very bad cancer, just period. So gastric cancer really poor prognosis in general. However, if you find it in early stages, then obviously surgery gives them the greatest hope of potentially long-term survival. So in this patient who has especially a form signet ring, then the potential for us getting the patient to surgery would be the best hope at giving this patient the longest progression-free survival, or at least overall survival potential. My only question, major question is one: when we were doing this 3 cycles of DCS, what were the sizes that you are looking at to measure so that we see after 2-3 cycles how well has anything improved? Obviously, it's usually harder with diffuse kind of tumors because, as you rightly said, they actually go along the mucosal lining. So it's very hard for you to get a diffuse mass. But if was there any discrete lesion seen? The other question would be, endoscopic ultrasound in some of these patients actually be useful to see the depth of invasion and also the size of that invasion. you really want to know that has the neoadjuvant generally done anything better for this patient, so that when you take them for surgery, you know that once surgery is done, we can actually give them another 3 cycles of DCM, because we know in the neoadjuvant setting it was actually working. So I don't really know how we are determining how well this neoadjuvant works. The issue of preparing the patient for total gastrectomy is important, very true. But quite a number of these patients that I've seen have always had, you see on CT scans and you see before surgery that everything looks localized, and then when the surgeon goes in, they find this diffuse disease. However, how would you know unless you go in to check? So I like the idea that the surgeons are going in to first of all look and see, and if they see extensiveness of the disease, then obviously total gastrectomy is out of the question. But my question, do we know how well a sense of this neoadjuvant and how well it's done?
So he says that the symptoms started 2 months before diagnosis, and he could not even eat. The thought of food and the smell of food made him vomit. So I think that he was quite symptomatic. After the neoadjuvant, he says that he's able to eat and drink without vomiting. So he has some symptomatic response, which is good. In terms of the size of the tumor, I think that's very hard because I didn't actually see that he had gotten a pre-op CT scan. That's new to me when Sylvanas just presented, but maybe that's something they brought in when they came and got admitted. He had only in his file had gotten an ultrasound of his stomach, which showed thickening of the stomach on ultrasound pre-neoadjuvant. Now the tumor isn't actually a localized mass, it just shows thickening on CT scan. So again, it's going to be a very hard marker to trend on this disease process.
And Sylvanos, do we know, like when they say the thickening, do they have, a size of how far the thickening was? I know it's really hard to see on CT, but did they say all throughout the entire, circumferentially?
They didn't comment.
Like a third of the stomach, half of
They
it?
didn't comment.
Usually when they do endoscopic ultrasound, will actually be a better one to visualize than actually the CT. But anyways, we'll work with what we have. Have we done another CT after the neoadjuvant? Okay, that can be compared with the previous one.
Yes.
So, I think I don't know whether anybody on the online with any other suggestions is welcome. But from my standpoint, I think the plan by the surgical oncology team is pretty good. Okay, we finished that case. Any other case?
Yes, Kisumu has another case, the last one.
Okay, continue. Can you continue from Kisumu, then we'll have ours.
So we are loading up another case after your case, but you guys go first.
All right. All right, good morning. My name is Arthur Juan. I'm a fifth-year medical student. I'm presenting a case of breast cancer. So a case of self-referral from the Khan University Hospital, where she's been on treatment. She presented with left breast cancer, which was diagnosed in March of 2017. So the history of present illness from oncologist at Aga Khan showed an invasive ductal carcinoma grade 2, ER negative, PR negative, HER2 neofish positive with no distant metastasis. Also with chronic renal disease with compromised renal functions. She received 6 cycles of paclitaxel and trastuzumab with minimal response.
Don't worry, we can read that. Just say Herceptin.
Okay. Subsequently, she received 3 cycles of epi and cyclophosphamide with minimal response to local disease. She also received 2 cycles of oral capecitabine from December of 2017 without response. From February, she received palliative radiotherapy to control local disease, and she completed on 4th of April 2018 with no response. Family and social history, there's no history of cancer in the family. She has never smoked and no drank alcohol. She's a housewife with 6 children. Food and drug history, she has no known allergies and has been on chemotherapy for breast cancer. On examination, she's an elderly woman. She was weak and sick looking, ECOG2. She wasn't pale, not cyanosed, not dehydrated, had no edema, and she was febrile. Vital signs were normal. On systemic exam, breast examination, she had a swelling present on the surface at the right chest wall region, and the right breast had a mass present in the upper outer quadrant. The left breast was shrunken, with skin showing burnt up area due to radiotherapy. The other systems are essentially normal. CT scan report, there's CT scan of last year, 8th of March 2017. That's the only one that they brought. There was left breast mass, which was the reports showed that associated breast wall thickening and axillary lymphadenopathy consistent with non-locally advanced left breast tumor with left axillary nodal involvement. No CT evidence of metastasis to the lungs, abdomen, and pelvis. The 5 millimeter non-obstructive left lower pole calyceal calculus. That's the current state of the breast, and that's one as compared with the right breast. This is the drug she's currently on, though she had the last she completed this last week, and it's only she gets it from India, but right now they can't get she's out of it. So our point of discussion was, where do we go from here? Are there any investigations we can do? What can we give her from here, and any other suggestions? Thank you.
Okay, so we'll open up the floor for suggestions, questions, and clarifications. Anyone?
Hello, this is Eli from Gynae Oncology. I'm just wondering, the quite a number of no response treatment that this patient has gone through, and therefore it raises the question: how long should you persist with the treatment when you know there is no response? I believe there are ways in which you can determine the response to treatment and stop at some point.
You guys would want to hazard an answer to that one?
No,
my question is, what do you mean by no response? Because when I look at those two breasts, one looks definitely smaller. So for some reason, I'm wondering, what were the response that you are looking at? Do you want it to grow bigger? Like, what was the initial size of this tumor in March of 2017? What was the size of the mass?
Unfortunately, we don't have any report. That's the only report with the CT scan that you have about the responses, and that CT scan that she carried with her. So there's nothing else we can base.
But when you guys say no response, what do you mean? Like the patient said, I'm not responding, or what was it?
No, that was the that's what the oncologist wrote from in a referral in his referral letter to us.
And were they writing like what they were looking at, like the mass was 6 by 6, and after treating it was still 6 by 6, therefore no response?
No.
There is more details in this patient that we don't really know what was going on, because clearly that breast looks smaller, and they went ahead and did radiation. Of course, we have some radiation changes on the skin and scarring that can be seen. So we really need more information on this lady. She seems to have a lot that we don't know. Because it's important whenever they do the treatment, they gave 3 cycles of this, then we find out from those 3 cycles, I go back to Ellie's point, what was the reason for treatment? Like, what is the goal? So the goal of treatment, if it was to shrink the tumor in the neoadjuvant setting for a potential surgery, was that goal achieved? And if the tumor was this size, you guys make sure that any patient you see, measure the size of the tumor. Because then when you are treating them, you want to know whether your treatment is having an effect or it's not. So unfortunately for this, I'm not so very sure, but I'll ask around. Any other thoughts to this question? Any other thoughts or questions? I think these patients, we need a few more details. Let's get detailed information about if you can just send information to us on the HEMONC site on our WhatsApp with saying that initially at the treatment, this is what was found, this was what the stage was, and axillary lymph node. They gave these 3 cycles, and this is what they saw had happened. They gave 4 cycles, and so has the patient had mastectomy or no, or lumpectomy or something? No, never. Yeah, so we want to know whether all this what happened because the tumor itself is actually auto-amputating the breast because of the rapidity or progressive disease, or the patient is reacting like this because she responded a little but not completely to the chemo. All this is actually radiation-related changes. So it's important to check that. When was the last CT scan for her done to evaluate her treatment? How long ago? If it's more than a month ago, it's important for us to have a new one so that we can review it with the initial CT. This is a patient we need to talk more about. I think I still have incomplete information. However, lapatinib should continue. Lapatinib, just like Herceptin, these are HER2 drugs that are effective in these patients. So because of her HER2 status, you would have wanted to give initially trastuzumab. But quite a number of patients, and there's a lot of data that you can give both trastuzumab and lapatinib in a patient with HER2 positive breast cancer that is continues progressing with metastasis. So usually what we do, we will give trastuzumab. If a patient comes back with the cancer progressing and is still HER2 positive, because we have to check for that again, then they can actually replace both trastuzumab and lapatinib. Get it in India only.
Yes, you get it
In our setting, we are really working hard to try and get trastuzumab in our center. So if we get in our center, we'll let you know in one of these tumor boards that is available. But we have it, but patients have to pay all that money for it, and most patients cannot afford. So we are trying to see whether the drug company can give us a very big discount, and we'll share that. So for this patient, just give us a little more details, and then we can discuss. I think this is unresolved unless somebody has. This one we may not be able to resolve in this meeting. We can talk about it later. Next.
The question.
Since she's on the lapatinib now and at times getting it is a challenge, can she be also on the loaded?
Yeah, please get close to the microphone.
Okay, Dr. Dagi, I'm saying since getting lapatinib is a challenge, and if you get it here, it's very expensive. You can only get it in Nairobi.
Yeah.
I'm asking if Zeloda would be of help now to her.
I think I looked back and I saw in one of your areas you had said she had been on Zeloda with no response, wasn't it? Yeah,
Yes.
so if somebody has not responded to a treatment, if we reintroduce it later, you are not going to surprise the tumor. Yeah, so you can actually look, there are other drugs like I normally put patients, but this is really in palliative setting, what we call metronomic, chemotherapy. You give them a little bit of methotrexate, a little bit of this and that. Some patients respond to it. It's kind of like wish-wash of treatment. But I could look for any of the drugs that she has not been on before and give you one that is available and send you on email or on a text message. I'll review this and see what she has not been on. We really need to give her something she has never used before to improve her outcome.
And can she be on a combined therapy?
Yes, she can. Depending the combination therapy, the most important determinant of that is usually one, her performance status. If her performance status is still very good and she's still strong, we still can do a combined therapy because we are getting pretty thin on when we can do. If you miss that window when she's very strong and able to take a combined therapy, then you may never get back to it. Once we start going monotherapy, you are unlikely going back to combine. Because with each therapy, her body gets weaker and weaker from all these treatments. We are doing our last case over here, and it's being presented by Dr. Millicent.
Okay, so good morning. My name is Dr. Millicent Korir, and I'm going to present a case on breast cancer. So this is a 52-year-old female called EMW from Molo. And it's a patient who we've been seeing since 2013 on treatment for metastatic breast cancer. But the reason why I'm presenting her is that she has a sternal mass for the last 1 year. And so she's a 52-year female with metastatic breast cancer diagnosed in September of 2013 via lumpectomy. In 2014, a mastectomy was done and she was referred for radiation therapy but was lost to follow-up because of financial reasons. She came back to hospital a year later in 2015 with a recurrent mass and was started on adjuvant chemotherapy in November 2015. So she got 4 cycles of AC and then 4 cycles of taxane, which she completed in February 2016. She had a resection of the mass in 2016 and referred for radiation, and she received 30 sessions at Texas Cancer Center in June 2016. The patient was on follow-up and an evaluation was later done in April 2017, which showed recurrence of the disease with the left axillary lymph node involvement and lung and liver metastasis. So the patient was started on palliative Zeloda in May 2017, and she did 8 cycles and finished in October 2017. The patient was well until February 2018 when she presented with an anterior chest wall lump over the sternum and has been growing since then and is associated with pain. So on her past medical history, this is she has had previous admissions. She's married, a farmer, and an NHIF contributor. Her review of systems was unremarkable. So on general examination, she's in fair general condition, not pale, not jaundice, not cyanosed. She's performance status 1. On local exam, the right breast is normal with no axillary lymphadenopathy. The left breast, there's a mastectomy scar, which is healed and dry with no obvious masses on the site. However, there's a 4 centimeter mass elevated and fixed over the sternum. It is hard and tender and has no axillary lymphadenopathy. That's how the mass looks like. So in summary, this is a 52-year-old female with a metastatic breast cancer, had a lumpectomy done in 2013. Histology showed an invasive ductal cell carcinoma with positive margins. MRM was done in 2014, was found to be ER/PR negative. She did 4 cycles of AC in 2015, had a recurrence in January 2015. Lumpectomy was done, which showed grade 3 disease histologically with positive margin and lymphovascular invasion. She received 4 cycles of docetaxel and 30 sessions of radiotherapy. A follow-up CT scan showed liver and lung metastases, and she got single-agent Zeloda 8 cycles, which she completed in 31st October 2017, and now presents with a painful anterior chest wall mass fixed to the sternum. So that's a CT scan after the mastectomy, which showed that lung fields were normal, no evidence of metastasis, no evidence of pleural effusion. There was a cystic mass on the anterior sternum, which was 4 by 6 centimeters. The bony calvarium appeared normal. The other livers, other organs were normal. This was the histology from that mass, which showed grade 3 disease, invasive ductal cell carcinoma. Sorry, this is not very clear. I think I didn't take the pictures nicely. And then this was a CT scan done in 2017 after recurrence that showed a mass that was 1.3 by 1.2 centimeters with liver lesions. So my point of discussion is what next for this patient.
I have So this mass that is on the anterior chest wall, even after mastectomy, there was a mass which was 4 centimeters by 1. Did we ever biopsy that mass? It was a huge, 4 centimeters by 5 is huge.
Initially this mass was very small, but has been growing over time.
But the test done after mastectomy, the CT scan, showed a 4 by something centimeter, 4 by 4, 4 by 5.
Yeah.
So it shows there was a mass even after mastectomy.
Yes, we did
So
not.
did we ever biopsy to find out whether this mass was the breast?
No, we did not. We didn't.
Any other question?
Yeah, I agree we should have biopsied that mass. Then secondly, I don't know your local data about recurrence after radiation. It seems to be pretty short. Less than a year?
So this patient, to be honest, like let's go back to the first present, like the first slide. So if you look at the first slide, this is the main reason why I do not advocate for breast conserving surgeries in breast cancer in our setting, when you cannot really put them to radiation soon enough, and when you cannot assure of negative margins. So if you look at this patient, diagnosis September by lumpectomy, and then it took another several years before the mastectomy was done. But look at what this patient is doing. Came back to also 1 year later, breast recurrent mass after not accessing radiation. So if you are not going to offer patient radiation, the best surgical procedure to do is actually modified radical mastectomy. And that's why we encourage that. I'm not saying that with modified radical mastectomy, it negates the issue of radiation, but at least you know you've taken as much tissue as possible to avoid this recurrence, and especially in the breast. Then the other thing I've noticed, there are several reasons for you to have recurrence in the chest wall immediately or a few months after radiation. One can be that the patient already still had positive margins at the time of radiation. Two can be poor radiation. They don't map it out very well so that they radiate the entire tumor. Whatever they've left out, it starts actually getting. Three can be that you did not give the neoadjuvant treatment at the appropriate time as it was given, like a step was missed. So if you do surgery and then you don't give adjuvant treatment, you send them straight to radiation, then you are not really doing corrective treatment in this patient, and there's a potential that there are already some metastatic micrometastasis around the area. Even when they do radiation, likely that it will come back. So this patient has a lot of areas in which it was everything was missed. Anyway, additional question. So from here, we got 4 cycles of AC was given. So did we ever do HER2? It was negative. So, and this is the thing, patients' triple negative disease is actually highly aggressive. One of the issues is that you don't really have a biologic or something that will target. So you cannot say, I'll give this patient tamoxifen or aromatase inhibitor or anything. So usually the drugs that have been known to be very effective in this patient is platinum-containing agents. So if I have a patient with triple negative disease, I don't give them necessarily ACE. If they come in metastatic status, I give them carboplatin and paclitaxel. And actually, I do have 2 patients that are 7 years out from the time I treated them with carbotaxel, and they had metastatic stage 4 disease, 1 to the brain. So it shows that there is actually a role of platinum agents in this patient, and there is a physiological reason for it, which we can't go into right now. The drugs that she's received, let me go back to the first slide. She's already received that, so that's it. What else has she received? She received Zeloda. And how has been her, have we been monitoring what we are calling progression? Like, what is it we are monitoring? Yeah. Yeah. So it needs actually being biopsied and resent for ER/PR HER2. The reason is this: most patients that even at the time they have a primary tumor, if you find it was ER/PR negative, HER2 positive, some of these tumors actually change, and that when they have the metastatic disease, it acquires a positivity or a negativity of the initial testing. So whenever whenever a patient comes, this is actually a good learning point. Whenever a patient comes with metastatic disease, even if, unless the duration between the time you diagnose them with locally advanced metastasis is a very short duration, showing there's progression of disease. If somebody has been disease-free for a year or 2, when they come back and there is metastasis in the liver, that's why you see us trying to do ultrasound-guided liver biopsy, so that whatever we get, we can actually send it for ER, PR, and heart. And on the off chance you find it now positive, then this patient can benefit from those tamoxifens and aromatides. Yeah. So I would actually stand back for that. I would biopsy this mass in the middle as well to be sure that this mass has got nothing to do with nothing. And that CT scan you said was which date? April. Oh my God, she has not had a CT scan since then. So do we know where we are? You know, it's like we are in the sea, and the only thing we know, we left the coast last week, but we don't know where we are going. We don't know. So this patient needs actually CT of the chest and CT of the abdomen. We need to figure out whether she has any bony metastases. That will change the choice of treatment we give her. And then just list for me nicely all the drugs that she received, and potentially she can tell you what the response was. By the way, guys, let's not leave the patients to be telling us the response to therapy. Yes, they can tell us subjectively, but we need to, as doctors, as clinicians, we need to have an objective, verifiable way of saying this has responded. Not just saying no. That's an only member, even my grandmother can say that. I mean, you need to say, now this tumor that the patient had 3 axillary adenopathies that were measuring 1, 2, 3. Had cervical adenopathies, there were 3 in number, there were 50, and measure them. And then you can say, now we have 1 axillary adenopathy. So it means 2 have gone. The patient is actually doing better. So patients can feel better when the tumor is still growing. You know that. There's a potential. Not always, but can. So what we just need to do is let's be very good at measuring this and learn a little bit about the RECIST criteria, R-E-C-I-S-T, RECIST criteria. This is the criteria that we look at how we are rating the response of tumors in solid malignancy. So you have to know when it was 5 centimeters or 4, what is it at the moment? It's important, it helps. Because the patient will ask you, how am I doing? And you say, well, how do you feel you are doing? If you are not measuring, we shouldn't leave it to that. So these patients, all the ones that are presented today, unfortunately, no one has been telling me the starting point. So when we get to the end point where we are, we can't make a good decision unless you know where you are initially. With her, I would like her to be staged again, and then biopsy distance in the middle. Then we can present this next week to get the results. Do you have any pathology? We can talk to Dr. Kibet and team to give us results so that next week we can conclude this test. Any question, and then have the palliative team involved. It needs a lot of psychosocial counseling if you didn't know, because after going through all that hell and from 2017, it probably really needs a lot of help. Pain management is crucial for her, nutritional support. If there is any family issues, transportation back to forth in the clinic, let us know. We'll help her out. Any questions?
Is there any setup with social work to determine whether or not a patient can get radiation therapy? Because I had a patient come last week and they had said maybe we can raise funds for radiation, and technically she could have gotten potentially a breast conserving therapy, but after some discussion we decided to go with the safest route. But for me as an outsider, maybe it's more difficult. I just don't know if there is from the social work perspective, if there's a way to screen a patient to know whether or not they can get breast conserving therapy, because I think there are some patients who have money who can probably access the radiation.
So I think that is over to your department now, to the palliative team. I think they should. I think the same way you look at whether they can afford chemo or all that, is just to find out the cost of all this radiation and to tell them the importance of how soon after surgery they should get it. Because the problem, some of them will say, I'll raise 80,000. And unfortunately, they'll raise it in a year. I mean, when you follow it up, not years. So I think there is I think you should be referring them to the palliative team. And then you guys just know that we've negotiated with Aga Khan Hospital, and radiation for single radiation for our patients coming from 4,200. Yeah, we are signing off this week. So 4,200 a day. We've already sent somebody to charge that. And instead of 10 or 11,000, see, that's a good thing. And then in addition, they can have their chemo here and all that, so they don't have to pay chemo on the other side. And I said even CT scanning and all that we can do using NHIF. If you have NHIF covers 3,600 shillings for the first 20 sessions. So if you are paying 4,200, it means you'll be paying 600 shillings only for the first 20 sessions, and then the rest become 4,200 for them. So, and most of the time we're doing 32 to 35 sessions. So I think we have a likelihood of the patients can be referred here who need radiation. Then we can talk to them and see how we can do radiation and send them with a note from us. We are about to also get into an agreement with Nairobi Hospital, and Nairobi Hospital, the radiation, they've reduced to 6,000 for our patients who don't have insurance. If you have NHIF, then it's still 3,600 covered, so they'll pay 2,400. This is much better than the we send them and it's 10 or 20 or whatever.
And how long is the waiting line for them to get radiation? Oh.
So if you send a patient last week, they are actually, I think, over the queue that we need to organize for them. They get, so what we do, we tell them these ones are coming. They go day one, it's marking and all that, they do the stuff. So there is no queue for this side. That's why we are trying to avoid Kenyatta National Hospital. I mean, yeah, well. And the other thing I learned over the weekend is that Kenyatta University Hospital it's actually the best hospital in Kenya right now. But of course, we do not push it. So it has a linear accelerator that is state of art. It has the best one. Anybody has ever been there? It's nice. It's beautiful. And it's just sitting there. Maybe more universities should move anyway. But we hope to get our own soon, hopefully. But in the meantime, we can help patients. Any quick questions?
Oh, just if radiation is really changing and it's becoming more accessible, then at some point, once we see the results from that, we do need to have a conversation about breast conserving therapy then.
I totally agree. And I think that we'll put Kani in charge of giving us a lecture one of these days on breast conservation, indications and all that, so that we can start preparing. I think that would be nice. Because honestly, nice for them to get breast conserving surgery, but what we don't want to do is we don't want to compromise their potential for cure or for long-term survival because of the delays we've already seen. So this is actually a typical case of the reason why I make a case for radical mastectomy. Okay, thank you so much. Next time, please, let's start at exactly 8. Please. But I'm very, very grateful for all the presentations. And the Kisumu team, any thoughts, questions? Or have
what has been your take? Yes, I have a question.
Yes.
Yeah, what has been your take or other observation for patients who've been on docetaxel? Yeah, because like for us, other than the cost, one other issue why we have not been so aggressive with the use of docetaxel is the adverse drug reactions associated with the docetaxel.
Actually, I don't see that much. I'll tell you this though.
Yes.
That so docetaxel, if you get what you are getting probably is impure docetaxel or from one of these. It depends on where you buy it from. I remember there was a time here, like I think 2014 or 2015, we were having quite a bit of reactions with docetaxel, but now we don't have. No, we don't. And we've been giving my oldest patient to give docetaxel to was 94 years old, and they actually do very, very well. So I think part of the problem is just that review and see where you are ordering the docetaxel from. Because I agree with you, there are some people who complained about some generics really having a lot of impurities and causing a lot of hypersensitivity. There is a patient that I remember we almost lost several years ago. Because just became very hypotensive, was sweating, was palpitating, and doing all sorts of things. Was managed to be saved, but we avoided docetaxel like plague. So the point is just that let's look at where you're ordering from, and you can work with my pharmacist to see where we get ours. Okay. We don't get that anymore.
Okay, fine. Okay, thank you.
Yeah, and also I've been reminded, which is true, by Anne, that the rate of infusion is also important. So you don't just want to pump it in and just rush away. So most of it, you start slowly and see how well they are reacting to it before. But the thing I've noticed to be the most common reason is poor drug or poor generic.
Okay.
Okay, thank you so much, and see you guys next time. Oh, do we have a surgical one on Thursday or no? At 2? Do we meet at 3?
Yes, we will meet on Thursday.
So Thursday at 2, you are all welcome for a surgical oncology tumor board. And the Kisumu team, you can prepare 1 or 2 cases if you have. We have our surgical oncology team that will be here. and I'll also be attending. So let's prepare something. Okay, thank you so much. Bye-bye.